Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the U.S. Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Caroline Cromwell, and I'm Assistant Professor of Medicine at the Icahn School of Medicine at Mount Sinai. I'm also Medical Director of Thrombosis Services Program at Mount Sinai Health System in New York City. I'm delighted to join you today to moderate today's webinar. Today, we will take a deeper look at the topic of anticoagulation stewardship and optimizing treatment for venous thromboembolism across the continuum of care. First, we have to do a little housekeeping and a poll. I'd like to go over a few points for joining the webinar. Upon joining this webinar, you will see two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. All audio will be muted. At the end of the presentation, we'll have time for questions. To submit a written question, use the questions area of your toolbar. We will try to respond to as many questions as we can at the end. The webinar will last about an hour, and the webinar is being recorded. We'll start with two audience polls. We'd like to get to know a little bit about you. Please select your answers to the poll questions. Which of the following best describes you? Healthcare provider, public health professional, person with DVT/PE or family member, part of a community-based organization, or industry partner. Let's see. Okay, we mainly have healthcare providers, but we also have public health professionals, patients or people with family members with a history of DVT or PE, as well as industry partners joining us today. Okay, we have our next poll question coming up. What region of the world are you joining us from today? North America, South America, Europe or Russia, Asia or Africa, Australia or New Zealand? Let's see our answers. Okay, not surprisingly, majority from North America, but also South America, Europe, and Asia represented. It's nice to see coming from many parts of the world and joining us today. Thank you for joining. Okay, it is really my pleasure to begin to introduce Dr. Alison Burnett, who is a national expert in the area of anticoagulation stewardship. For some of you, this may be a new area and you're here to listen and learn. Others also may be more well-versed in this important topic. There are going to be more and more patients who are on anticoagulation for a variety of conditions to treat or prevent thrombosis. Patient safety, quality of care, and effective management are all of utmost importance. And that's truly what anticoagulation stewardship is about. And we're here to learn more about how pharmacy leadership, engagement, and collaboration is really vital and key. Stewardship teams, modeled after successful antimicrobial stewardship teams, are designed to really oversee safe anticoagulation prescribing across hospitals and healthcare systems. Dr. Burnett is president of the Anticoagulation Forum. She's also an antithrombosis stewardship pharmacist at the University of New Mexico Hospital. She's also associate adjunct clinical professor at the University of New Mexico College of Pharmacy. Dr. Burnett, welcome, and let's begin.
Well, thank you so much, Dr. Cromwell. Let me just say it's a genuine honor to share this platform with you today. And I'd like to thank the CDC and the Division of Blood Disorders for the opportunity to talk about this important and timely issue. And I'd like to welcome all of our attendees. Thank you for joining. I'm going to attempt to take control of the slides now. Yep, looks like I got it. Okay. So neither Dr. Cromwell or I have any relevant disclosures. And our objectives for today include describing anticoagulation stewardship and why there's an urgent need for such focused clinical initiatives around VTE. We're going to discuss how pharmacists apply stewardship to ensure appropriate prescribing and delivery of evidence-based anticoagulation regimens to our VTE patients. And then as we move through the presentation, I'm going to highlight some available resources and educational opportunities to aid clinicians in improving care of VTE patients. So I want to start by framing the magnitude of two major issues. The first one is the number of patients that are experiencing VTE. And the second is the number of patients that are experiencing harm from anticoagulants. So let's start with VTE. And what I'm showing you here on the left, this is population-based surveillance data from the Worcester VTE study that was conducted over a 25-year period in Massachusetts. And what the investigators found in this analysis, that the incidence of venous thromboembolism, that is new cases, essentially doubled during the study period. Now, they appropriately acknowledge that some of this was due to increased diagnosis, due to non-invasive imaging and more PE events being found. But they also acknowledge that there were other significant contributing factors like age, obesity, and increasing rates of hospitalization that is driving this increase in VTE incidence. On the right, what you're seeing is a retrospective claims analysis conducted over a 5-year period from 2002 to 2006. And in this analysis, the investigators found that the prevalence of VTE, that is all existing cases at any given point in time, increased by 33% during the study period. And then when they applied US Census estimates and projected out, this suggests that the prevalence of VTE is going to at least double by the year 2050. So clearly VTE is and will continue to be a major public health burden, and we need more effort and resources and dedicated attention to primary prevention of VTE and also optimized management of VTE to prevent secondary recurrence. Okay, second major issue, increasing incidence of anticoagulant-associated ADEs. Anticoagulants are the cornerstone of treatment for VTE. These are highly effective therapies used by millions of people across the world. And the concern is that they're also high-risk therapies. And we're seeing increased incidence of adverse events despite having the direct oral anticoagulants, or DOACs, which were designed to be safer and were actually shown in clinical trials to be safer than more conventional therapies like vitamin K antagonists. And what you're looking at here, this is surveillance data from the CDC, and they've been tracking this for nearly 2 decades now. And you can see somewhere around 2013 or 2014, anticoagulants in the red line actually surpassed antibiotics in the green line to become the leading class of medications associated with harm in the outpatient emergency department setting. So this is a very concerning negative trajectory for this important class of medications. And we're not just seeing this in the outpatient setting, we're seeing similar patterns in acute care hospitals. We're seeing it across all types of post-acute care facilities. So clearly we have a lot of work to do in this area. And I'll just point out, since we're on this slide, look at that green line with antibiotics. You see that it's been steadily decreasing. And I firmly believe that's because of focused, dedicated antibiotic stewardship initiatives. And as Dr. Cromwell alluded to, we're trying to emulate that as much as possible with anticoagulation. So when you take this rapidly increasing number of patients who are experiencing VTE, along with an increasing number of patients who are experiencing harm from anticoagulants, that's clearly not ideal, and it's basically a recipe for disaster. So we have this impending health crisis, and I think it clearly calls for swift, broad, and decisive action in the form of anticoagulation stewardship. Anticoagulation stewardship goes well beyond what we've historically done with anticoagulation, which is basically anticoagulation management. It was often siloed in clinics and often just focused on drug management. Stewardship provides a more holistic, multidisciplinary approach to anticoagulation management that spans the continuum of care. And it's really more focused on disease state management rather than drug management. And importantly, it involves continuous quality improvement. So we need to be consistently looking for and identifying any barriers and then capitalizing on any opportunities to improve patient care. So back in 2019, the Anticoagulation Forum partnered with the Food and Drug Administration to develop 7 core elements around successful implementation of anticoagulation stewardship programs. And when we did this, we intentionally emulated exactly what antibiotic stewardship leaders had done back in 2014 with the CDC. And then most recently, we were fortunate to partner with the National Quality Forum to publish the resource you're seeing here, and Advancing Anticoagulation Stewardship, and Implementation Playbook. And this resource does a really nice job of providing granular details on each of those 7 core elements. And it also provides examples of how to implement and expand stewardship initiatives. So we're really excited about this. We think it's going to greatly elevate our visibility and our momentum around this, this initiative. And it's available for free download either from the Anticoagulation Forum or the National Quality Forum. So please be sure to check out this resource and share it with all of your colleagues. Obviously, the best way to manage a VTE is to prevent it, okay? You know, data suggests that we need to do a better job of increasing awareness around VTE for both the public as well as clinicians. There was a global survey that was done back in 2015, and the results are shown in that top graph there. And what it revealed was that the public has very low awareness around VTE, much lower than for other disease states like stroke or myocardial infarction. So we have some work to do there. We also need to optimize our VTE prevention strategies within our hospital systems. Up to 60% of all patients with VTE were hospitalized in the last 90 days. So hospitalization is a major risk factor for VTE. And I don't know, not a lot of institutions have done an optimal job with VTE prevention. And I think there's some things that maybe aren't even on our radar screen. And a great example of this is the incidence or the prevalence of refused doses of prophylaxis or missed doses of prophylaxis. There's an excellent team of multidisciplinary clinicians up at Johns Hopkins. They've done some really great work on this if you want to explore it in the literature. But their research has shown that 10 to 15% of all ordered doses of VTE prophylaxis are omitted, and a leading reason is patient refusal. So what I want, you know, the key message I have for the clinicians on the call is, if you're prescribing prophylaxis in your institution, don't assume that your patient is actually receiving it and being protected. When you go back, make sure that your institution is looking at this, make sure you're promoting good stewardship to minimize these omissions. All right, we're going to turn to treatment of VTE, and we're going to start with a case vignette. So we've got a 53-year-old woman. She presents to the emergency department with an acute proximal DVT. She's got a history of seizures. She's obese, and at home she's on phenytoin and baby aspirin. So in the emergency department, she's prescribed apixaban 5 milligrams twice daily for 14 days. She's told to follow up with a primary provider within 2 weeks. Unfortunately, she misses that appointment because she had to go to a job interview that she absolutely could not miss. And so she completes this 14-day supply of apixaban, and then she stops her anticoagulation because she no longer has a valid prescription. So hopefully there are multiple aspects of this patient's care that are jumping off the screen at you, ways that we can improve care for this patient. So she was prescribed a DOAC, which is not surprising because these agents now dominate the landscape for both VTE as well as atrial fibrillation. And this is based on evidence from randomized controlled trials. This is a meta-analysis of the VTE trials here, showing that these agents provide a 50% reduction in major bleeding and a 60% reduction in intracranial hemorrhage compared to vitamin K antagonists. Another way to think about this that I love, and it's from Mark Crowther, a friend and colleague many of you know. If you choose to use warfarin and low molecular weight heparin to treat a VTE, you're doubling that patient's risk for a major bleed, and you're tripling their risk for an intracranial hemorrhage or a fatal bleed. So that's something we definitely don't want to do. And now the DOACs are guideline preferred. We want clinicians to be thinking of these agents as first-line therapies. An issue in our case vignette is that the patient was prescribed the wrong dose of apixaban for her acute VTE. She was prescribed 5 milligrams BID when she should have been prescribed 10 milligrams BID for the first week with an eventual dose de-escalation to the 5 BID. And this off-label dosing issue, it's not uncommon. This is data from the Vte multinational VTE registry. And in an analysis of this registry, they found that up to half of patients who were prescribed a DOAC for either initial therapy or ongoing therapy for VTE received a wrong dose or a wrong regimen. So for example, apixaban once a day instead of twice a day. They didn't see any difference in major bleeding or death, but there was an increased VTE recurrence in patients who received off-label dosing or an off-label regimen, as seen in the dashed and dotted lines in the graph there. Whereas patients who received on-label dosing or prescribing had lower event rates in the solid black line. So, you know, we've placed a lot of confidence in the DOACs. And rightly so, if they're used as they were in the clinical trials. But I think there's some unintended consequences with the DOACs that we have to account for and now deal with. So in addition to off-label dosing, we also see inappropriate prescribing, like, for example, patients who aren't good candidates being put on DOAC therapies, and this places them at risk for harm. We also see issues with suboptimal management, particularly in regards to like drug interactions, and especially in the perioperative period, where clinicians that might not be familiar with the dramatically different pharmacokinetics of the DOACs compared to warfarin are trying to manage these agents as they would warfarin, and that's not appropriate, and it puts our patients at risk for adverse events. And then the last issue is that, you know, we have fewer touch points with our patients because these agents don't need routine monitoring. And, you know, lots can happen in the interim between visits. Patients can develop contraindications. Patients can lose access to medications. So all of these challenges in conjunction with this robust uptake of DOACs has led to the realization that while DOACs don't require routine monitoring, they clearly require specialized management by anticoagulation experts if we want them to perform similarly to how they did in the clinical trials. And that involves anticoagulation stewardship. So bringing multidisciplinary anticoagulation stewardship to the front line for our VTE patients really revolves around 3 big areas. And these include optimizing antithrombotic prescribing and use to get these patients onto and off of therapies appropriately. We also have to ensure consistent access to these anticoagulant therapies to avoid gaps and outcomes, adverse outcomes. And then we need to ensure we're promoting safe and effective care transitions because these patients are high risk all the way around. VTE patients may have an acute VTE. They're obviously going to be on anticoagulants, so all of that collectively makes that patient very high risk. And so, pharmacists are well positioned to help drive these stewardship initiatives. And I want to demonstrate this as we go through the remainder of the presentation by highlighting some pharmacist-led antithrombosis initiatives that have been published in the literature that demonstrate feasibility and impact on patient care. So let's start by looking at optimized antithrombotic prescribing. One way we can do this is using standardized systematic stewardship tools and processes that help identify patients who are and are not good DOAC candidates, as well as promoting DOACs as first-line therapy for our VTE patients. And what I'm showing you here is a simple, it's a screenshot of a simple DOAC eligibility checklist that we embedded into our EHR platform. It's right in the pharmacist workflow, and they use this for all the patients that are coming in, and it helps them quickly assess whether a patient is a good candidate or not, both from a clinical standpoint and a financial standpoint. So we check all of our co-pays, et cetera, before these patients are initiated on therapy. It's important to mention that as the evidence evolves, you have to make sure your stewardship tools evolve. And so we've had a lot of revisions to this checklist as use of DOACs has expanded into cancer and into obesity. Now we're starting to see movement into the renal impairment realm. So just a simple example of how you can implement a stewardship tool into your hospital to drive stewardship initiatives. In addition to appropriate patient selection, we need to make sure that we're optimizing dosing, right? And this can be difficult because dosing varies across indications with the DOACs. Sometimes it requires adjustment for renal impairment or weight or age or drug interactions or some combination of these. And so there's a number of publications in the literature of pharmacist-led DOAC initiatives, both in the inpatient setting and the outpatient setting, that have shown optimization of DOACs through dosing, correcting dosing, but also importantly, improving adherence. And so both of those are very viable process measures that serve as good surrogates that should likely lead to improved patient outcomes. And I want to emphasize that as you go into the literature and you explore these examples that I've highlighted, and there's multiple others, you'll note that they often started as some small pilot project or proof of concept. Many of them were done through pharmacy resident projects. The key point here is you don't have to boil the ocean. Don't try to tackle everything at once. Start small, gain some traction, and then build on that. One of the key interventions that we can make for our anticoagulation patients is antithrombotic deprescribing, right? So we know that combined antiplatelet and anticoagulant therapy is associated with increased bleeding risk. And there's a growing number of areas where patients who require therapeutic intensity anticoagulation are able to have their concomitant antiplatelet either de-escalated or even discontinued. And this includes coronary artery disease, mechanical valves, remote cardiac stenting, and of course, primary cardiovascular prevention. So a number of anticoagulation services have implemented standardized systematic processes to evaluate and intervene on these patients. And I've shown a couple here, again, resident research project at our place. But this should always involve multidisciplinary discussion, particularly with the antiplatelet prescriber, and shared decision-making with the patient and the family. But I want to emphasize really quickly, think strategically, think small. Don't try to build everything in one day. Figure out how you can take one of these ideas and start implementing it to gain some traction at your institution. Okay, let's talk about ensuring access to anticoagulant therapy, because this is a huge non-quantitated, unquantifiable, if you will, area where pharmacists are navigating and helping the multidisciplinary team, often in conjunction with case management and social work, et cetera. And it's an area where it has its own navigational skill set and its own knowledge base. It's complicated. So let's talk about this a little bit. Access to meds is absolutely critical for acute VTE patients because they are extremely high risk for recurrence in the first 4 weeks, as you can see in this graph here. So when a patient's diagnosed with an acute VTE, we have to make sure that they have access to medications, both physical and financial. And many hospitals have implemented meds to bed programs, which is very convenient and ensures the patient has the initial supply of medication in hand before they leave the hospital. When you're interviewing the patient and working up the care plan, you need to probe for transportation issues, and if those are identified, the patient needs to be presented with potential options and solutions. And I know at my hospital, our care managers are very helpful in providing bus passes and vouchers, but often those are only temporizing measures, so you've got to keep your eye on this ball. Sometimes we can set patients up for mail order options, and that's a viable approach. Anticoagulants, as many of you know, can be very expensive, particularly the DOACs, or enoxaparin is extremely expensive out of pocket. And sometimes, surprisingly, third-party payers are still requiring prior authorizations or even warfarin step-throughs, meaning that patients have to first try and fail warfarin before they're considered for a DOAC. And that requires a prior authorization. Those prior authorizations can still be pending at the time of discharge. So you have to have some sort of systematic process and tracking mechanism to make sure that the loop is closed on that and the patient is continued on therapy that they can continually access. There's a number of patient assistance programs, and we'll look at them briefly here in just a moment. But before we move on, I just really want to emphasize that this has to be assessed not just at the beginning of therapy, but with regular cadence for the duration of therapy, because access to medications can change over time for any number of reasons. Okay, so we've got several options to try to help get patients their medications. We have 30-day free supply cards for the DOACs. We also have copay cards. There's also pharmacy coupons that you can print out and use for the patient. And then there's also manufacturer programs that will actually deliver the medications directly to the patient. Each of these have their pros and cons, and they all, patients have to meet certain criteria. So again, this is tough to navigate. It takes time, it can be complex. So either you have to train yourself to be familiar with this, or you have to find somebody who can help you navigate it. And I know I rely heavily on several colleagues across my organization to help me navigate this, to make sure the patient has access before they leave my care. Because of the higher cost of DOACs, and along with less frequent visits for DOAC patients, these patients are vulnerable to falling into the donut hole, and we need to be aware of that as clinicians. We need to ensure regular touch points with our patients, and maybe a little bit more frequently in the latter part of the calendar year, or certainly empowering them by providing them with a way to contact you, their patient portal, a safety net phone number, etc. So when they do run into issues, they can navigate and advocate to make sure they don't have gaps in care. So access to medications can definitely be affected by health inequities, and this is driven by socioeconomic status, access to healthcare, and of course implicit bias, which occurs when we as clinicians make assumptions about a patient's ability to pay, or perhaps a preference for a less expensive medication. We need to be really cognizant of eliminating or minimizing these inequities, and some stewardship actions we can take to do that include standardized shared decision-making approaches to ensure that patients are considered equitably for all types of anticoagulants that may be appropriate for them. We also have to avoid preconceived notions regarding their ability to pay or a particular preference. And we need to be sensitive to trust issues when we're talking about newer therapies that they might not be familiar or comfortable with. And then lastly, we certainly always want to empower our patients. And a great way we can do this is to connect them with advocacy groups like the National Blood Clot Alliance, which will provide them with excellent educational tools, navigational expertise, and also provide community and support. All right, let's pivot now to promoting safe and effective transitions of care. As I mentioned, these are high-risk junctures for our VTE patients who are on anticoagulants. And the most common type of care transitions we think about when we hear that phrase is discharge from the hospital back to the community or to a post-acute care facility. When we have a patient with an acute VTE, outpatient treatment for low-risk VTE events is preferred. And it's been made very easy to do this with apixaban and rivaroxaban starter kits because they use a single drug approach. The starter kits are very convenient and clearly delineate when the patient should de-escalate their therapy, et cetera. This can happen very, very quickly, particularly if it's happening in the emergency department because they want to free up bed space. And there are a lot of things that need to be put into place before you let go of that patient, particularly if they have an acute VTE. And that includes things like thorough anticoagulation education with teachback, getting that patient's phone number for telehealth visits or follow-up phone calls, scheduling all the appropriate referrals, appointments, and placing the referrals. There's a number of things, and you can see these listed out to the right here. And so because of this, and to make sure our patients don't receive suboptimal care, it's strongly recommended to use a Vte Discharge Checklist to go through methodically and make sure patients have everything they need, including meds to bed, et cetera, before they leave your care. The Society of Hospital Medicine just published a very cool implementation guide around this, and it's a program called FAST, which stands for Facilitation of Anticoagulation for Safer Transitions Program implementation guide. And this, I believe this was actually started by pharmacists at University of Thomas Jefferson Hospital in Pennsylvania. So again, another pharmacy-driven initiative. This implementation guide is free to download. So I would encourage you to check this out. Maybe this is a type of stewardship initiative you want to implement at your practice. Another concerning area of care transitions with anticoagulants, as I've already mentioned, is the perioperative period, because DOACs are not anecdotally managed appropriately in this setting. I wanted to highlight this project, another pharmacy resident research project that was recently done at Leahy Health this year. And what the pharmacy resident did in this non-interventional study was they simply observed practice patterns for providers managing DOACs around procedures and compared that to the institutional protocol for hold and resume times that's based on the PAUSE study. And just from a high-level view, looking at this table on the left, you can see that the adherence rates with that protocol, they're not great, right? And some of them are concerningly low. And I think another big concern is that a lot of the time, these patients don't even have their perioperative plan documented, which is concerning with high-risk medications, but admittedly, even at my own shop, it's very hard to standardize and operationalize that. I think the other cool part of this project that I wanted to share was a survey that they distributed to these providers. And you can see on the right here that less than half of them have a standardized way of documenting perioperative plans. Concerningly, about a third believe that bridging is needed with DOACs, which we know is not correct. And then very few of them feel comfortable doing this, and almost 100% feel that a centralized approach to DOAC perioperative management is needed. What a great opportunity for anticoagulation stewardship, right? And pharmacists are well positioned to do this because, you know, they're familiar with the pharmacokinetics, et cetera. And I think that's actually what Leahy is doing. They're taking this data to their leadership to petition for additional FTEs to implement an anticoagulation stewardship around the DOACs in this setting. So it's a really cool project, and I congratulate them on this. There's other types of care transitions that we see with our VTE patients on anticoagulation. Sometimes we have to switch between therapies, like if their PA is denied or they develop a contraindication. We're conducting dose de-escalations for patients continuing on reduced dose DOAC for extended therapy. All of these require standardized evidence-based, appropriately timed interventions, and they're largely based on pharmacokinetic parameters. So pharmacists, again, well poised to promote safe and optimized anticoagulation care for these patients. So I want to come back to this case vignette. So I see several opportunities. You know, she was on phenytoin at home, likely not an optimal DOAC candidate, and perhaps you know, drug interaction checking or some type of checklist might have flagged this and given us direction to either prescribe a different anticoagulant or talk to the neurologist and see if we can get her on a different anti-seizure medication. Now that she's requiring therapeutic anticoagulation, we definitely have to revisit this aspirin, and if it's not indicated, we need to get it stopped. We talked about optimizing dosing for this patient, and I think she had significant challenges with access to medication. So a better approach in this situation would be to prescribe a starter pack and then and make sure refills are in place so she can get at least 3 months of therapy once we've ensured that it's covered by insurance. And then she needs, you know, maybe some more assistance with access to healthcare providers. So providing her with a contact number or encouraging her to use a patient portal when she runs into issues like running out of medications. Okay, I would be completely remiss if I didn't emphasize the importance of patient advocacy. And National Blood Clot Alliance, that is hosting this webinar, is the premier organization in this space. And they do a phenomenal job of providing education. They empower their patients and members, and they do a really nice job of promoting psychological well-being and support. And I'll just, you know, admittedly, this last point of psychological well-being, it hasn't been adequately addressed in the past, but I'm excited to share that NBCA is now doing some research in this area with a qualitative research survey called the CLUES study. This is the critical look at understanding emotional suffering of blood clot survivors, and this is being led by Dr. Rachel Rozovsky. This survey was launched on the NBCA website and across social media platforms in August of 21. And by January of 2022, they already had more than 3,300 responses. So I think this just underscores how much patients want to shine a light on this issue and talk about it. The results were very compelling. It showed that at least half of all VTE patients experience some appreciable degree of anxiety, depression, pain, or they have problems with performing their usual activities. So this is compelling data. We need to pay attention to it. We need to figure out how to build stewardship around this so it's consistently addressed with our VTE patients. I wanted to share a couple of educational tools with you that you can use to enhance your knowledge around diagnosis management and stewardship for VTE. The first one is an e-learning course on VTE that's brought to us from a partnership between NBCA and the CDC. You can access this for free at stoptheclot.org. And also the Anticoagulation Forum, we're having our next boot camp October 7th and 8th. If you haven't already, please register. This is going to be a fun 2-day immersion into all things anticoagulation. It's virtual, but you will get to interact live with world experts like Scott Cates and Jeff Barnes and Sarah Vasquez. So be sure to check that out. So I'll leave you with 3 takeaways that I hope you'll take into your practice and share with your friends. The first is that optimizing VTE management requires multidisciplinary anticoagulation stewardship across the continuum of care. And pharmacists play a vital role in translating evidence-based VTE guideline recommendations and best practices into actual patient care actions. And there are several organizations available to you with resources to advance your knowledge, to also implement anticoagulation stewardship, and to promote patient advocacy and well-being. So make sure to take advantage of that. All right, with that, I'm going to pause. I'm going to thank all of the attendees for their time, and I'm going to turn it back over to my colleague, Dr. Cromwell.
Thank you so much. That was really such a wonderful talk. You really covered a lot in a small amount of time regarding anticoagulation stewardship, just how really impactful it can be, and really how it can be so impactful regarding many different areas. For me, sort of as a hematologist, and I really focus on the area sort of systems-based hematology, this really falls right there in terms of it's designed to kind of improve care delivery for the patient. So I think that's really just falls right in that spectrum. One thing I wanted to ask you, or I think others would ask, is what are ways or how would you help, let's say someone like me or someone who wants to help bring this to their hospital? How would you either advise kind of initiating stewardship in a smaller hospital, or where this concept may not be kind of fully supported? How do you even say they would help kind of argue this point to the powers that be at their hospital, or where might be the first best place to start?
Yeah, it's an excellent and common question. And, there's a variety of ways that you can delve into this, but I would say, if you're working in a place that, doesn't have any appreciable degree of anticoagulation management or stewardship in place, and you're limited on resources, you got to get creative. One of the first best pieces of advice I would offer is figure out what motivates your hospital administrators. Like what public measures are they having to report on? What medication standards or accreditation standards are they needing to achieve to continue to receive reimbursement dollars, right? One of the most common examples that we give when we're coaching people on implementing stewardship is the Joint Commission's National Patient Safety Goals, right? So if you're a Joint Commission accredited hospital and you want to stay accredited, you got to make sure that you have those elements of performance around anticoagulation in place. And if you don't, you can use that as a lever and a talking point with your administration to say, hey, we've got to get compliant. Give me a few resources. Let me show you what we can do. We'll come back to you and we'll show you our results. So aligning with what the universal operating plan of the hospital is, and any regulations that they need to achieve. The other thing I will say is, if you're limited on resources, start small. Find something that you have an issue with, right? A good way to do this is examine the types of anticoagulant related adverse events you're having in your hospital, or an area where you're having like egregious overuse of medications or inappropriate use, and target those and build a small PDSA, Plan, Do, Study, Act, a small continuous quality improvement initiative around it. I will say a lot of times in the beginning, that has to be volunteer work. There's no resources for it, right? You got to find the people that are passionate, the people that are going to help you go out and do it, and the people that are going to help you get the data, because data drives decisions. And then when you have that, you can take it to your hospital leadership. Okay.
Plan, Do, Study, Act. I love that. So essentially finding what's impactful for your hospital and obviously for the patient. So around cost, safety, helping the patient experience, arguing that towards your hospital to show how helpful this can be.
Right, okay. And there's a lot of good information around that in that implementation stewardship implementation playbook that I mentioned. So go download it. There's tons of good stuff in there.
Okay, thank you. Okay, we have a question from the audience. It seems like a management question for pharmacy. What is your choice of anticoagulant for a patient with creatinine clearance less than 15 or patients on dialysis?
Well, I have lots of questions already as a clinician. I would want to know what the indication is, because if it was for atrial fibrillation, there's actually some emerging data that, one, shows that warfarin may actually be more harmful in dialysis dialysis patients with AFib than no anticoagulation. So it doesn't seem like warfarin's a good option in those patients. There's also evidence to suggest that DOACs might be a viable option, particularly apixaban. It's not based on high quality data, it's all retrospective, but it was apparently compelling enough to lead to the American Heart Association, American College of Cardiology to include apixaban along with warfarin as an option for atrial fibrillation patients for stroke prevention. So we do tend to use apixaban quite a bit in that population. The other big population, of course, is VTE, and we don't really know what to do with this. And one of the biggest conundrums is, what do you do with the induction dosing, right? It's a higher dose than for AFib, and the FDA labeling doesn't address it at all. It just says no changes in therapy are needed for apixaban, and to avoid rivaroxaban if the creatinine clearance is less than 15. So, but there's also some emerging retrospective data in VTE suggesting that apixaban and rivaroxaban may be a viable option in our VTE patients. We're starting to see a little bit of indication creep here. I wouldn't recommend it as a widespread routine practice, but if you have a patient who's not a great warfarin candidate, or perhaps they have issues with, like, calciphylaxis, etc., I think a shared decision-making conversation with the patient to talk about the pros and cons, the limitations of the data, and then also multidisciplinary discussion is reasonable. And if it's it's reasonable to consider using apixaban in that situation. I can't answer the question of what to do routinely with the induction dosing, because that's all over the map, including in my own stewardship program. So that's a case-by-case discussion.
Right. Okay. That was a great answer. And overall, I think clinically, we do, yes, tend towards apixaban for patients with low creatinine clearance and on dialysis, with plenty, yes, of caveats depending on their other medical issues. Mm-hmm. And there isn't, yes, great guidance depending on their indication for anticoagulation, why they're on it.
Exactly.
Another question, any good resource for guidance on inpatient perioperative management of VTE prophylaxis?
Man, that is an excellent question. Off the top of my head, I'm going to say no, because we are trying to, at UNMH, develop something along these lines. We have rough parameters, but it's not really anything formalized. I would love to see in the chat if anybody has a resource that they can point us to, or I would encourage any of the attendees, if you're working on something like this or you're going to develop it, please share it with the Anticoagulation Forum so we can put it in our centers of excellence and share it with all of our clinician members. Great question. Challenging situation.
Yes, great. Yes, anyone else can also share. Okay, let me see. Looking through the questions here. Someone said, thanks to Alison for helping me develop the stewardship program. So someone said thank you to you.
Well done. Do you have a name on that?
Let me
I'll have to send them an email.
Yes. Katie Toll.
Excellent. Great job. Keep up the good work.
Okay. Oh, what is your take on DOACs in low-income countries where DOACs are still inaccessible because of costs?
Yeah, well, I don't have that exact issue, but I can tell you in New Mexico, which is a largely indigent, very rural state, we often have to deal with patients who can't access DOACs because of the financial aspect, and that's a huge health inequity, right? In those cases, we have to get creative. We often default to transitioning them over to warfarin using a bridge. If that bridge is enoxaparin, that can be very costly out of pocket, and that's a situation where we would use one of those pharmacy coupons to get a patient a dramatically reduced out-of-pocket cash price. But we would then have to make sure the patient goes to the pharmacy, gets the medication, etc. And we generally, in that situation, we limit the number of syringes that we're prescribing to like 7 days to minimize the cost to the patient. So that really, means we have to do really good warfarin management to get them to therapeutic in a timely fashion. I don't know, I don't have a lot of experience for what occurs in other countries, and I don't know what's available. I would be interested to know if you have to take a similar approach with a conventional therapies with a bridge to warfarin.
I mean, I think that is such an interesting point and comment about equity, and I do hope in the future, as potentially as more DOACs become available or programs and support, that could be something that would become more accessible and available.
Right, and I'm not sure on the exact dates, but I believe the DOACs will be going generic, but not for another, I want to say 4 or 5 years. So this will continue to be a problem and will continue to drive health disparities.
Absolutely. Another question. It seems the Anticoagulation Stewardship Program centers around medication therapy management, access to medications. Do you have a VTE prevention mandate? If yes, can you provide additional information on how pharmacists can be a part of this?
A VTE prevention mandate.
I believe within anticoagulation stewardship, I think specifically, and how pharmacists play a part in that.
Yeah, well, I'll say, VTE prophylaxis, primary prophylaxis prevention is definitely a part of stewardship, and I think pharmacists have many roles in that situation. One, if you're in acute care setting, if you're the pharmacist rounding with your ICU team or whatever, you want to be sure you're checking for VTE prophylaxis in your at-risk patients, every single patient, every single day, every time on rounds. If you're, working in a hospital and you're not rounding, you need to have some sort of maybe surveillance report to quickly look at your population level. Here's the patients I'm responsible for today, who's on prophylaxis and who isn't. And I think a lot of hospital systems have those types of tools. Then, pharmacists can be very effective in making sure that patients don't miss doses of prophylaxis. Like sometimes nurses will want to hold prophylaxis prior to a procedure, but surgeons don't always want prophylaxis held. So pharmacists can work with nursing to ensure a reduction in interrupted doses, and they can also make sure that prophylaxis gets resumed in a timely fashion to prevent prolonged gaps that can set the patient up for a hospital-acquired VTE. The last thing I'll mention is it's not been widely embraced yet, but we've seen increasing use with COVID and with emerging evidence around post-discharge VTE prophylaxis, and that certainly requires a high degree of stewardship. So pharmacists can be involved by helping, risk assess patients, determining if they're appropriate candidates for extended prophylaxis, and then ensuring they have access to the medications. And very importantly, documenting when they're supposed to stop that prophylaxis so it doesn't continue in perpetuity. So those are just some thoughts off the top of my head.
Okay, thank you, thank you. I'm curious how you track your interventions and outcomes data.
Yep, great question, and a common, a challenge for sure. And the problem is that every system is different, right? And so you have to get creative on how you're going to do this. I will say in our system, we use a combination of things. We're on a Cerner platform, so we're able to query for what we call discrete data elements. So if it's a discrete piece of data like a serum creatinine or a drug like aspirin, we can run Power Insight queries to extract that data directly from our EHR. For my stewardship program, when I want to track metrics like appropriate use of PCC or INRs greater than 5 or HIT testing, we rely extremely heavily on REDCap, which is a very user-friendly database used by a lot of academic medical centers. And you basically can build your database, give access to people that you want to help put input, and then you can crunch the data and dump it out into Excel and manipulate it, et cetera. So it's not optimal at my place for sure. And I know there's some really high functioning places that even have dedicated data departments to help do this. It's going to be different across the spectrum. If you haven't delved into this yet, I would suggest if you have informatics people at your shop, reach out to them to start getting some ideas of how they could help you.
Yes, it's true. I mean, there will be a range of what people can use, and even starting small or with what your electronic medical records can give you is at least something to start with from big to small in terms of what you can track or follow. But that is a great question.
I remember I'm thinking back on, one of our most impactful interventions that's still in place and highly functioning and that we actually published was reducing inappropriate HIT testing in collaboration with our lab. And it was an Excel spreadsheet, and every time a patient got a HIT antibody, we just threw it in there for like 2 years, and then we went back and analyzed it. So sometimes it's very, very rudimentary. Don't let it hold you back. Get started, start small and start easy, and experiment.
Yes, absolutely. Right. Excel spreadsheets. Okay. Another question, does your stewardship program include pediatric patients?
Oh, excellent question. So very excitingly, we had a PGY2 resident complete his pediatric specialty residency. He decided to stay on, and he has now picked up the mantle to build a pediatric antithrombosis stewardship at University of New Mexico Hospital. It's very much in its infancy, pun intended, I guess. But yeah, he's starting to build great tools and processes for these pediatric patients, and it's being extremely well received across the organization. So I would encourage anybody who takes care of pediatric patients to look to consider pursuing that.
Yes, I have heard of that more recently, but yes, definitely. Can you reiterate the FAST acronym?
Oh, I wish I had it in front of me, but I'm going to try. Facilitating anticoagulation safer transitions, or something like that.
That was it.
Was I close? Okay.
Yeah. Can you share DOAC preference in obese patients?
Well, yeah, I mean, we rely heavily, on the ISTH guidelines, and of course, those are focused on VTE, but we feel comfortable extrapolating that data to AFib. You'll read in those guidelines that rivaroxaban has the most evidence, so I think we tend to gravitate towards rivaroxaban for those patients, but I think apixaban is certainly an equally viable option.
Yes, I agree. Asymptomatic, thank you so much with your patience with the questions. There are many, and we will not get to all of them as we do have to stop soon. I am trying to catch possibly another one, and we will try to respond in another way if possible. Okay, let's see. I think we went over some of these. I'm trying to catch the ones that are sort of asked in many ways, similar ways as possible. Okay, let's see. If someone is referencing, yes, to check the most recent CHEST guidelines for some questions, which can be answers. Yes, thank you for bringing up a reference to that.
I'll just say thank you, ACCP, for revised perioperative guidelines. Excellent move.
Yes, yes, absolutely. Also, Alice and I have discussed the PAUSE trial, which also the PAUSE study, which many hospitals use to help guide perioperative management, which also advises that typically bridging is not needed for direct oral anticoagulant on patients in the setting of atrial fibrillation.
Right, but again, that's a setting where even though it was in AFib patients, most clinicians in practice are very comfortable extrapolating that to VTE.
Yes, good point. Absolutely. Okay, I think that is essentially what we have time for, as I see that it is 3:03. I did just want to thank everyone for their time today and all of the excitement about this topic. I really appreciate everyone for staying with us. I wanted to thank Allison Burnett for her amazing slide presentation today and all of the engagement. It's really been a great hour. I wanted to thank the CDC, the National Blood Clot Alliance, and this wonderful webinar series on blood disorders. If you have any questions at all, please contact Cynthia Sayers at csayers@cdc. This webinar will be archived. You can see where, so I think there were some questions about where this can be viewed again. So you can watch it as many times as you would like. And really thank you again for joining us today, and please have a great afternoon.
Thank you.